Okay, welcome back. ICI to Jerusalem, to the new cath labs of Hadassah Medical Center. First, we've got a debt that we need to pay and conclude the previous two cases. So as I concluded in the first presentation, TAVI, valve-in-valve went very well. The gradient post-valvotomy was, post-dilatation, was actually 2 to 3 millimeters of mercury, no AI, patient is having coffee in the recovery bed. The second case, as you may well remember, was a bit more complex. So Ronen Be'eri, Professor Be'eri, would you please conclude what happened to our patient, the redo mitral valve?
So after we signed off, we repositioned the clip closer to the two previous clips, and the results will be, I'm hopeful that you'll be able to see in a moment. Do we see the results? So we remained with a mild to moderate or moderate mitral regurgitation, which actually its origin is between the new clip and the two older clips. And if we can switch to the next image, we'll see the pulmonary venous flows, which started with very diastolic dominant flow, almost a reversal. And now you'll be able hopefully to see. Can you pass to the next, I marked it? The next image, please.
Super stiff wire.
Okay, thank you. So you're able to appreciate that now the flow is systolic dominant, and which demonstrates reduction of pressures inside the left atrium of this patient. And we decided at this point to stop there, and the patient remained with this moderate or moderate mitral regurgitation and went on to recovery.
Okay, so two cases are done, and we are now to begin the third case. And as promised, aortic and mitral were first, and now it's the third case, a tricuspid. And let's go to the case presentation.
Yeah, let me tell you, Chaim, who is here: Eberhard, Grube, Victor Guetta, myself, and Robert Gill. So we are anxious to see more structural work. Eberhard, coronary is gone.
Okay, with such a distinguished faculty, a distinguished panel, I think we chose you quite a nice case for the after-lunch break. This is, as you can see, the team with me: David Planner, on the interventional echo, Ronen Be'eri, our chief of echo, our good friend and anesthesiologist Yuval Meroz, and of course the team, Halima, Saadi, all the good guys with us, good boys and girls with us. And let's go to the case presentation. Okay, so this is a 54-year-old gentleman that presented with worsening right heart failure, New York Heart Association, functional capacity 3. As you can see, Dudu Planner is working, and I'm talking, which is actually the best I can think of. Medical history of this guy: congenital pulmonic stenosis, underwent back in 1976 an open pulmonary valvectomy, then a few years after, surgical pulmonary vein replacement with a Magna 31 and a tricuspid valve replacement with a Magna 29. This was 8 years ago. The post-surgical course was a very difficult one, with very long recovery time, and even after this one, he underwent right lobectomy due to pulmonary sequestration. In addition, AFib, hypertension. Next slide, please. So, Ronen, can you please tell us a little bit about the echo?
So what you can see here actually is the left side, which is completely normal. You can already appreciate the RVOT, which is severely enlarged. Next slide, please. And as you can appreciate, we see here a huge right atrium. We see a biological bioprosthesis in the tricuspid position. And what can you already appreciate is the severe tricuspid regurgitation, severe intravalvular, and we'll see it in a moment, tricuspid regurgitation. And also you can appreciate the very large pisa in diastole, demonstrating significant stenosis of the bioprosthesis. Next slide, please. And as promised, you see that the mean gradient of this valve, mean diastolic gradient of this valve is corresponding to severe stenosis of this bioprosthesis. And the patient does not have pulmonary hypertension, which is also important in this case. Next slide, please. And in three-dimensional echocardiography, and I'll demonstrate it again in a few short moments, you can appreciate that the valve leaflets are very thickened and the motion is reduced, and actually the anterior leaflet of the valve is completely immobile. We don't see it very well here. We have better 3D pictures online now. Next slide, please.
So here you can see a reconstruction of the CTA demonstrating the huge right atrium and the cross-section of the tricuspid valve, the surgical tricuspid valve, and up you can see the pulmonic valve. So this is part of the challenges we have in this case, the huge right atrium, lack of support, and the distorted right ventricle. Next slide. So the indication for a tricuspid valve implantation in this case was a degenerative surgical valve with a tricuspid regurgitation plus stenosis. Advanced symptom despite maximally tolerated medical therapy and high surgical risk. The patient is post-3 surgical intervention in the chest and severely dilated right ventricle, right atrium. In the last surgery, the surgeon had to connect the pump to the femoral artery and vein prior to the surgery. And he had an extremely complex post-op course. Although the STS seems low, we know that this is the STS based on the mitral intervention, and we know that it doesn't reflect the true surgical risk. And there was a heart team decision, which was also a consensus to offer the patient percutaneous tricuspid valve-in-valve. Next. So we have specific challenges with these cases that severely dilated, as we said, the RV and the RA with distorted RV and reduced RV function, significant tricuspid stenosis, which may impose difficulties in crossing, both with the wire and then with the valve. And he has post pulmonary valve replacement, which may also make difficulties in crossing upwards to the pulmonary artery. Next. So our strategy was, although we can do it in local anesthesia, we decided to go general anesthesia and to do TE to have the full availability of the best imaging. We chose the femoral vein for access, and we're now about to do the pre-dilatation of the severely stenotic valve. And we may, if we need to control the cardiac output, we decided not to put in a pacemaker, but rather to reduce the inflow with an occlusive IVC balloon. But we'll see how the pre-dilatation goes, and if we need it. And post-dilatation balloon of the valve is optional as well. Next. Okay. Now, all right, ready? Let me show you what we've done so far. So we got femoral access, pre-closure with single proglide.
Chaim, can I?
Yeah.
I do have a question.
Yes,
Wonderful.
Eberhard.
Very, very interesting case, because we don't see this very often, obviously. And I have a question regarding the axis. Mm-hmm. Just an explanation for us. Could you imagine a transjugular approach, number one? And given the tricuspid stenosis and insufficiency, do you really think you need to predilate? I'm not asking this because of predilatation. I'm asking this for anchoring purposes. Do you really think you need to predilate?
So regarding the first question, we feel much more comfortable getting the femoral access, both for the access itself, and we see that coaxiality with the SAPIEN system is not supposed to be an issue. And also closure, control of the bleeding, we feel much more comfortable with the femoral access. We don't have much experience with the jugular access. And regarding the pre-dilatation, I know that it's a prosthetic valve, but mainly the issue here is stenosis. It's not regurgitation. So I'm not afraid, and the patient can tolerate. So I'm not afraid of like breaking or getting a dehisced leaflet, but rather, since it's an S3 system, I'm afraid of getting, between the valve and the delivery and the sheath without being able to advance the valve across the sapient valve across the prosthetic valve and getting stuck in the middle.
So this actually acting as a test case.
I think, Everard, your question about the jugular approach is very appropriate, given the fact that the right atrium is very big and coming from above, exactly, most probably you get a better control, exactly, of the delivery. So that's the question I had in my mind, and Abed also. Okay, go ahead, guys. Very interesting case for main arena for TCT and ICI. What kind of wire do you use?
This is a super stiff. And as you can see, we have it's quite a problem even bringing in the balloon now.
I mean, I don't have that much, I've only done this twice, but yeah, see, this is what I mean. Chaim, knowing coming from the mitral and aortic experience, and looking at the 3D, I'm a little bit concerned about the, when you pre-dilate, you have to rapid pace, and the right ventricle is compromised. So,
okay, so I'll put
yeah.
תכינו את 14 French.
So what size balloon did you take?
20 millimeters.
And what is the inner diameter of this valve?
1 second.
Just a second. Here we are.
This is not bad. So this is a 29 magna, so the inner diameter.
The question now is whether we'll have to actually improve our wire, trying to cross to the pulmonary artery, getting even more stability. As you can see here, it wasn't that easy coming up with the valve, and we wouldn't like to get stuck. What do you think, Dudu?
1 second.
This is the stiffest wire that you have?
No, we have Landerquist.
We have Landerquist, and we may consider, we thought of going to Landerquist.
Exactly. It will be difficult to do the turn.
Bring us a pigtail. Let's get a pigtail.
So we chose the super stiff because we initially were in the PA.
But we couldn't actually go through the catheter.
As you can see here. But while exchanging the catheter, or exchanging the wire, we came back to the RV. We thought that in the PA it would be safer and enough to use the super stiff.
פיקטל קתטר. פיקטל 5 פרנץ'. תראה לי שאנחנו שם, שלא יצאנו.
How is your experience? Do you control the cardiac output with rapid pacing, given that you are implanting a tricuspid valve, so you can either do a left ventricle pacing or sinus or coronary sinus pacing, or using IVC balloon?
Want to try the multi-purpose first?
I want to say a few words. This is Victor. Hi.
Yeah.
Hi,
Victor.
Great case. There are two ways to support with the wires, as you said. One is going to the pulmonary arteries deep, using swan guns and then a catheter and then putting the wire. The problem here is that it's a prosthetic pulmonic valve.
Correct.
You can tear the valve, you can destroy the valve.
Correct.
With the stiff wire. So I would do as you did, continue to put the wire in the left ventricle. But I think you need to have much more wire. The shape of the wire has to be allow you to be more in the ventricle. I think maybe you don't have enough wire in the left ventricle,
and that's why we're trying now to go
This is one thing. And regarding your question, we would pace.
Maka?
Not.
Okay.
Okay.
Again?
The problem with pacing is where from. You cannot put a pacing lead in the right ventricle. We've done a case previously pacing through the coronary sinus.
That's what you can do.
In addition, we had a case that we actually reported giving adenosine, reducing cardiac output for a few seconds, which were enough. But yet, we think that our main, that in this output, we'll be able to manage, hopefully. This is
the
Landerquist.
Double curved Landerquist, which we hope will enable us a better stability in the RV. Okay.
Okay.
Pull
Shall
this.
we go?
Yeah.
Yeah.
Shall we go for the valve?
So regarding the valve, the S3, few points remaining worth mentioning. First, that you need to upload it in the reverse way as you usually do in transfemoral aortic valve. And that's what we did, and we checked the position of the valve.
Again and again.
And again and again. And which means the valve, the leaflet direction is towards the nose cone and the skirt is towards the handle. And now when we are inserting the delivery system, the E of the Edwards should face down.
It's facing down.
It's facing down now. So when we have the flexion, we'll get it in the right direction towards the RV.
Ron?
Yeah, I just want to mention the ultimate support would be if you do transeptal and you pull the wire all the way to the aorta, and then you have a rail, that's definitely going to be able to deliver it. Because the problem with the Edwards, once you need it, you commit it, you cannot withdraw it. I mean, you prepare the valve, you have to be able to transfer it.
We can hardly hear you.
But what do you mean transeptal? How will you do it transeptal here? If you do transeptal,
Go.
what are you going to go? How will you catch the wire?
From the right atrium to the left atrium, you're going to go to the ventricle.
No, but this is tricuspid. So if it's tricuspid, how is it going to help you?
Okay.
No, this is tricuspid. It's a good idea for mitral, but not tricuspid.
Because for the mitral, that's what
But tricuspid, you cannot do that. Tricuspid, you have two options: either to go to the pulmonary artery deep, or you go to the ventricle with a larger loop. And the concern is the angle that you have in the left atrium. And
Can
that's
you check
why,
ACT? Yuval, ACT, please. ACT.
It will take the wire out because of the angle, and that's the advantage of going from the jugular in this case.
Exactly, exactly. So
Correct.
Just imagine that you come from the jugular, how soft is the curve.
תנו.
We want to make your life hard, Chaim.
רגע, אדוורדס הפוך, תאי הפוך. This. And now it has to be...
תן לי רגע.
אחרי תתן לי להתקדם טיפה. push wire. חכה שנייה. יכול להיות שאנחנו יותר מדי. Let's track it like this now. Then wire.
There. עכשיו.
Okay.
תן לי להחזיק.
תמשוך את הפושר.
Yeah, you don't have much freedom to pull the wire a little bit.
Yes, you're
בואו
right.
נמשוך את הפושר.
Here we can push feed wire.
No?
Feed wire. Okay, 1 second.
Can you pull a little bit?
Yeah,
We're trying.
Oh, no.
we'll try to pull the pusher a little bit.
Yeah.
Pull the pusher. Let's do the end. No, אתה לא יכול.
לא, אתה צריך את הפושה. תן לי לנעוד. אוקיי. בואו ננסה ככה. אוקיי. גו.
רגע. תן ווייר.
הווייר מתקצר לכם.
כן, כן.
נכון. עכשיו אנחנו
תן
בזווית
ווייר.
נכונה.
תן ווייר.
אתה שם. אוקיי.
Almost there.
Almost there. אני חושב שאנחנו טובים. עוד טיפה.
רגע, אנחנו צריכים עכשיו to push the sheath out and so we can... בסדר? תמשוך את השרוולית החוצה, אני חושב שזה יכניס טוב פנימה.
מה?
כאילו כרגיל, אתה יודע, לחשוף את הבלון.
רגע. את הפושה.
כן.
אוקיי.
עוד קצת שיס החוצה, בשביל ש...
אין לך את זה.
אין לך? אוקיי, בסדר. אוקיי.
What do you think, guys? Should we go?
It's very close.
Yeah, we'll insist about a few more millimeters in.
Few more millimeters.
Pull the wire back a little bit. Pull the wire back.
Maybe you can clockwise or counterclockwise hold the system together.
Okay, we're good.
Right here, yeah.
We're good.
Okay, so now very slowly, we're gonna inflate. חכה שנייה.
Let's increase the... Let's make up now. A pusher. Okay, there is a question.
Okay, very good.
Okay. I'm starting, Dudu.
Okay. Go.
Hold it.
Go.
Okay.
1, 2, 3, 4, 5. And down.
And we're done. Okay.
Just be careful now with the wire.
Very good.
Be careful with the wire, not to pull the valve.
Oh, okay. Ronen, it's your call now.
So we're going to assess regurgitation and stenosis. Let's start with the regurgitation. Let me get a better image. So we get a minimal anterior paravalvular regurgitation. And look at it from a different angle.
The main question that we're asking, Ronen, first of all, is whether we have any fluid. Because
the pericardial effusion.
Yeah, that's our main question. All the rest is secondary in this case. The valve is nicely in place.
Well, you don't have pericardial effusion.
Okay.
Okay,
So from
great.
now on, our main goal would be to keep this situation with no fluid. Now let's hear about the valve function.
Well, there's minimal anterior anteromedial paravalvular regurgitation. We don't have the pisa, the diastolic pisa anymore, and we'll look at the gradients now. So we go to mean gradient of 1, so stenosis is gone. And the next step would be to watch the valve in 3 dimensions, which is always a challenge with tricuspid imaging. As you well know, it's the toughest valve to image. So basically, we still see the wire there.
It's a catheter, actually, but yes.
Yes, and sorry. And you see the cage of the valve coming in the left atrium. This is a surgical view. Okay, so if I turn it down, anterior now is on the top of the image. Okay. And looking from the ventricle, it seems well in place as well. And I think it's a nice one.
Okay.
Yeah. Do you think we need, for sure we don't need to post-dilate, right?
No, we don't. I think we don't.
Can we see the pressure measurement? Let's do a pullback and see whether indeed we have any gradient.
Yep.
אפשר לעשות 0 בזה? Please 0. We have 0?
Okay, the pressures are so low that you don't see anything.
Yeah, no, something is not working with the pressure. אנחנו לא מחוברים.
Okay. Anyway, I think that
yeah,
we'll
we can. It's not a question, right? We don't have any stenosis or residual stenosis. So basically, we'll just pull back carefully.
Let's do a pullback carefully. We'd like the valve to stay in place, and I think that actually we're done with this one. Any comments from the panel or from the audience?
Very, very nice. Congratulations. That was really magnificent.
Superb.
Thank you.
So, thank you very much.
Let's hope that the pulmonary valve doesn't degenerate now.
We'll take care of it.
Here we'll need something much stronger than a Lundequist, I think.
Very, very nice.
Everything I think.
Very well done.